Okay, thank you. Thanks for asking me today. Really pleased to be speaking to you all, and I want to speak about benchmarking really, but from a Scottish Government and an implementation of strategy perspective, because I think that's what I've been asked to do is really, it's the so what question. You know, benchmarking has got loads of benefits, but how have we actually used it in practice? So I'm a professional advisor in the Scottish Government. I work in the Mental Health Directorate, and I'm involved in a whole range of programmes. But one of the first things I did in 2019, believe it or not, is it really encourage ministers and senior civil servants here to participate in NHS benchmarking, to join the network and to get the benefits of the network. So yeah, I'm not in control of these slides, so what I'm going to do is put this in the context of our strategic intent just now. So I'm going to say a little bit about what we're trying to achieve in Scotland in terms of our mental health strategy and delivery plan, and then give a couple of examples of where I think benchmarking is helping and could further help. So the first slide is really the case for change. Why do we have a mental health strategy, and why have we agreed a delivery plan with what's called COSLA, the Convention of Scottish Local Authorities? And I've summarised some of the elements of that. In general, mental health system of care and treatment in Scotland is essentially locally based, and there's lots of historical variation, and unwarranted variation is the term that we've used, and some emerging new needs that I think are becoming more important in public discourse. Neurodivergence is the most obvious one, that there's a growth in interest, reductions in stigma, and a growth in express demand. So our strategy and our delivery plan is trying to address these challenges and put it in the context of the next 5 years. There's just been an election in Scotland, and we have a government for the next 5 years. So it's a good time to be setting out our stall about what we want to achieve in that period. Next slide, please. So I mentioned this earlier. It was really, I'd been a senior manager in the NHS for many years. I've been a member of the benchmarking network. I've used benchmarking in terms of making the case for system redesigns, etc. So one of the first things I did when I went to the government was encourage us to participate. And I think civil servants have got a great deal of benefit from being part of the network. I'm going to say a little bit more about that later, because I think it depends where you are in the system and your role, the relationship you have with benchmarking and the benefits you get from it. So we've had some really quite substantial engagement with the network, and including specific commissioned pieces of work. But probably the most important thing we've done is encouraged the 14 territorial health boards in Scotland to be members and to contribute data on the annual cycle of the three main mental health and learning disabilities partnerships benchmarking networks. So we've had a great deal of benefit from that, which I'll go on to describe. Next slide, please. So the First Minister set out a case for public service reform last year, and essentially the status quo is not an option for public services. It's probably the same in other parts of the UK, but certainly in Scotland there's some quite significant structural challenges. And there's a document issued called Strategic, the SRF, the Service Renewal Framework, and we have a mental health version of that. So we've taken that key elements of that and asked the question, how can benchmarking help us with some of these elements? Next slide, please. And I've there we go. I've circled these. So the one in the middle top, I think, is really important, and I think benchmarking can help us understand this unwarranted variation. I think there's an added value of being part of the Home Nations programme, because we can understand what's happening in the other home nations, but also the international benchmarking report was really useful. I've had a discussion with colleagues in the network about outcome measures. We're very good at measuring inputs and outputs, when I say very good, we actually measure very little on a routine basis of the mental health system in Scotland. So, but we measure inputs and outputs. And tying all of that together in what we're calling a target operating model or a service blueprint, that's our intention. It's to take the learning that we have from the current system performance and the gap analysis and analysis of the evidence and what's happening elsewhere, particularly best in class examples from across the UK and internationally, and tying that into an operational model, a service blueprint. Next slide, please. So the first part of that is needs assessments, and the SRF document tasks us with, do you understand your population needs before you set out a strategic response to those needs? So next slide. And I think the highlighted areas, again, is where benchmarking has been really helpful, because we developed this policy over the last couple of years, and we were able to develop it informed by the benchmarking information that we had, starting in 2019. So we've got quite a few years where we can see changes in the benchmarking data, particularly through the pandemic, but also in the wake of quite a substantial investment in mental health services in Scotland in 2022. It was around £120 million, which is probably the single biggest investment in mental health in the history of the Scottish Parliament. So these aren't exclusive, of course, but analysing unwarranted variation in inequities and needs, something that is really prominent in benchmarking activity. Assessing and comparing service utilisation outcomes and unmet need. It was really interesting in Scotland for the first time to see comprehensively the difference between the 14 territorial health boards. We hadn't gathered the data and analysed it in the way that the benchmarking network do prior to that. And it was interesting. It prompted lots of debate once we saw that information. Next slide, please. So outcomes I'd mentioned, what outcomes should we be achieving, measuring and reporting? Next slide. This is what we currently report. And I understand looking at this, particularly from an NHS England perspective, where you've got the purchaser provider split, commissioning has been part of your system and process for many, many years. We moved away from that in Scotland in, I think, the year 2000, where we unified health boards. And so for commissioning, we call it planning. But I think some of the rigour that you have in the system is the availability of data and the requirement essentially for providers to account for the service that they provide, particularly when it comes to retendering and recontracting. So right now, these are the mental health measures that we routinely report up to a national level. And you can see it's quite a small basket of measures, and we need to do better than that. In fact, some of these are not outcomes, they're descriptions of how this system is currently performing. Next slide, please. We've challenged ourselves to look at, well, if these aren't sufficient, what should be? And I'm actually in a session today in what's now called Public Service Delivery Scotland with the Directors of Planning in Scotland, looking at this very question. We've spent the last 4 hours considering this. And I don't think I've got a finalised list, but what we're trying to do is get some order generating rule outcomes. So outcomes that drive the system to the point that we would wish, that's described in our blueprint. There's a big focus on individual defined outcomes, so essentially from the person perspective. And the WHO standards are really helpful in that. We're not gathering or reporting on these routinely, and I think that's a big challenge for the system. There are also some system outcome measures that we have to think carefully about. So, for example, we've got an objective that's about shifting the balance of care from hospital to community. Putting that in some outcomes that encourages the right sorts of behaviours and improves quality of services is a challenge. But that's the journey we're on just now. And I understand from Joe and colleagues that this is a discussion within the network, and we'd be happy to be part of that. Next slide, please. again, just some more examples of some of the outcomes that we're considering in this discussion that we've had today, and there'll be further policy work done before we put proposals to ministers. Next slide, please. So the big discussion today was baselining. People, the directors of planning across Scotland are quite honest about saying we really don't understand in a consistent way how the current service is performing. And that's because there's very little routine reporting on mental health treatment and care. Our ambitions for a blueprint are beyond traditional mental health care in the NHS, community mental health teams, psychiatric inpatient admission. But even in those areas, we've got a real dearth of information. So the first challenge, and one of the things that we agreed today, was benchmarking can help us to step towards a point where we are gathering consistently a basket of information that helps us understand the current service delivery and, importantly, the gap analysis. Next slide, please. Just some examples from work that we've done previously, and you can see this heat map, which shows quite a significant variation in Scotland with regard to beds per 100,000 population. I know from work that I've done in the past and in other care group areas that bed provision is quite a big driver of expressed demand. And I think when we also look at the way beds are used in Scotland compared to the other home nations and internationally, there's quite significant differences. There's also differences between the areas, as you can see from the various shades of blue in the map of Scotland. And again, this is prompting curiosity and driving questions about, do we have the right balance of care? Do we have the right bed model? Do we have the right community services supporting those beds? Next slide, please. Another example of this in the variation of bed occupancy. And I mean, these reports are, as you know from your own experience of benchmarking, 70, 80 pages, and we've got 3 or 4 years data now, so I could go on at length about how different Scotland is from elsewhere and how different the different providers are in Scotland from each other. That's one of the commitments that we've made in the mental health strategy, essentially reduce unwarranted variation. And it's one of the things that ministers speak regularly about, using the term postcode lottery. People, I think, in the Western Isles are quite happy to understand why the healthcare that they receive in the Western Isles is different because of the population and distance from urban centres. But I think people don't understand why that difference isn't planned and can't be explained. Next slide, please. And another example, variation in admission rates. You'll see all the green bars tend to be clustered at one end of this slide. And there's quite in comparison with the other submissions across the benchmarking network, we're at one end, largely at one end of this histogram. Again, it was surprising to my Scottish colleagues to see this, and it really prompted curiosity. Next slide, please. I mentioned the international comparison. I remember, I think the first time I saw these slides was at the Global Leadership Exchange conference in Dublin. And it was really fascinating to see for the first time Scotland compared to other places in the world and some of the metrics and the differences. We had a visitation from a minister from, I think it was New South Wales, who brought our ministerial team to Scottish Government, and it was fantastic to have some of this data to compare and contrast. Our colleagues in New South Wales were really interested in the difference between the Australian examples, and there's other data that illustrated that, and the examples in Scotland and the UK. Next slide, please. So how is this going to help us design a blueprint for mental health? Next slide, please. The case for change, I think I've mentioned. There's a level that the government is pitching at, which is a minimally sufficient set of standards to be achieved without being overly prescriptive. And I think the overly prescriptive does not then take into account the quite significant rural urban differences in Scotland, and each of the 14 territorial health boards are very different places to provide healthcare in. So there has to be a local set of dynamics. The Scottish Government are trying to specify what good looks like without overly prescribing and undoing some of the innovation that needs to take place. So that's essentially the reasons for developing a blueprint. Next slide, please. And some of what we need to help us do that is, again, the meeting I've been at today has been talking about which level should we be doing work at. So essentially, local authorities in Scotland times 32, some of them quite small, around 100k population or less. Health boards can be quite small too, but some of them can have 3 or 4 local authorities. We've now got a new structure called subnational, which is really cuts Scotland down the middle on the map and creates two populations of 2 million plus. And then there's the national population. So what needs to be done once for Scotland? We agreed some order generating rules today to try and build from the ground up. So essentially gateways before you would agree that something could only be done at the next level. And I think the highlights here are where benchmarking can help us in the absence of routine data. So what do we have currently against the mental health quality standards? A benchmarking process could help us understand that. What's the gap analysis? A deeper understanding of the current system in each area and comparisons against best practice, and just improving data overall. You know, benchmarking isn't the same as having routinely available operational data, but in the absence of that, then it's a really good step towards what you would need in the future. Next slide, please. I thought this was quite useful, a description of what the current system is and what we would want to change in the blueprint model. And we were actually talking about this today in terms of outcomes. If some of the right-hand column could be turned into reportable outcomes, it would drive the sorts of behaviour that we wanted to see. I think these are probably best described in terms of the individual's experience going through mental health support and care. And our scope is from the community all the way through to specialist tier 4 care. So the challenge for us is to turn some of the right-hand descriptors into measurable outcomes, and that's the next stage of the process I've been involved in today. Next slide, please. Again, the elements of the blueprint. I mentioned earlier the government's role. You know, we've got an important policy, legislative scrutiny and assurance, and resource allocation role, but I think some of the operational detail needs to be left to the system. So we're trying to strike a sweet spot between describing the outcomes for people that a blueprint should provide. So we'll get ministerial support for that without over specifying and getting involved in some of the operational detail that needs to be done locally. A couple of things in this list that I think are probably, well, one is probably not known to you, and that's the acronym was GIRFE and GIRFEC, which is getting it right for everyone, getting it right for every child. These are important policy cornerstones in Scotland that describe how the whole system should work to essentially meet needs. And it's a real challenge to the compartmentalisation, of the system that we see just now. So, you know, single point of access versus multiple points of access, single shared record versus multiple records, and having to tell your story over and over again. So we've really challenged ourselves in the blueprint to operate within the GIRFE and GIRFEC models, which essentially bring all of public services together to work in a shared way. Next slide, please. So, Joe.
That was your final slide, Stephen, I think.
I thought so. So yeah. Thanks very much, colleagues. I'm sorry to whistle through that, but I wanted to leave time for questions and contributions.
That's great.
That's brilliant. Thanks so much, Stephen. Really, really interesting. We've had a couple of comments which have been really helpful from Peter at NHS Greater Glasgow and Clyde, putting some context around it, which is really great. We've also had a question around from Rita, who was wondering around the outcomes and whether lived experience has been involved in describing what the outcomes should be.
This was a major item of discussion today. There was two areas that I think the group challenged ourselves. That's one of them. We do have a national stakeholders group that's called, it meets the minister regularly, and senior officials and senior colleagues in the system. And they are representatives of lived experience organisations across mental health and learning disability services in Scotland. So we do have regular engagement. There's a number of topic-specific engagements. For example, we were considering the needs of those with learning disabilities and autism, and there was consideration of legislation in Scotland. So again, a specific lived experience engagement there. The other group that I think that colleagues challenged, we challenged ourselves about today was the staff side arrangements. I'm not sure what that will be called in your area, but essentially this is a change programme. So lived experience can give us the guidelines and the destinations that we need to achieve. But I think we also have to bring our staff side colleagues with us, because actually there will be major implications for staff and practice and organisational change, etc. So that's one of the other things that came through strongly today.